Good evening, good afternoon, good morning, everybody, wherever you are. A very warm welcome to all of you to this new journal club brought to you by the International Academy for Clinical Hematology around the globe and across the hematology field. It's 6 p.m. in Paris, 7 p.m. in Athens, and 8 p.m. in Ankara. And it is my great pleasure to welcome you all to this journal club. I'm Mohamad Mohty from the Sorbonne University and Saint Antoine Hospital in Paris, in France. And I'll be moderating this journal club, which is dedicated, actually, the Scientific Steering Committee selected this paper recently published in the European Journal of Hematology. And you can see the title, Impact of Prior Treatment on Selinexor, Bortezomib, Dexamethasone Outcomes in Patient with Relapse Refractory Multiple Myeloma, Extended Follow-up Subgroup Analysis of the Boston Trial. And this is a paper co-authored by Dr. Mateos and colleagues. And actually, we're very lucky and fortunate, honored having today with us to discuss this paper, Professor Thanos Dimopoulos from Greece, who is a co-author, and Professor Meral Beksac from Turkey, who actually did not participate to this study, but has an extensive experience with the use of selinexor in the real life. So this is the abstract of the study. I will not go back to the design of the phase 3 Boston trial, which has been published and debated several times, more than 400 patients. So here we are talking about a post hoc analysis of progression-free survival, overall survival, and safety in a specific subgroup of patients, namely the lenalidomide refractory, the proteasome inhibitor naive, the bortezomib naive, and those patients who received only one prior lines of therapy. And actually, to make a long story short, with more than 2 years follow-up, you can appreciate based on these curves here. The blue curve is the selinexor, bortezomib, dexamethasone experimental arm, and the control arm is the historical bortezomib dexamethasone. And you can appreciate that whether you consider the lenalidomide refractory, the proteasome inhibitor naive, or more specifically bortezomib naive, or those patients with early relapse, actually the results are in favor of the triplet combination of SVD. When it comes, and I think this is something we need to discuss with the panelists, you can see that there is a specific pattern of side effects and adverse events related to the treatment. And we will discuss, I think, how to manage nausea, for instance, or thrombocytopenia in these patients. So without any further ado, I'd like to welcome our two panelists. Meral, Thanos, thank you for joining this ICH Journal Club. And my first question to both of you, and maybe we can start ladies first, before digging into the paper, just to position, I would say, the problem is about what are currently, what is or are, I don't know, the different algorithm for the management of relapse refractory multiple myeloma, because the field has been really booming with many new agents, especially immune therapies, antibody drug conjugates, but also small molecules like selinexor, not only single agent, but now going into combinations. So what's your today's summary, a snapshot about the management of relapse refractory multiple myeloma, Meral?
So thank you, first of all, Mohamad, for the kind invitation to be here. It's wonderful to be together with such a prestigious faculty. And regarding approach to relapse refractory, it's complicated and it differs from one patient to the other, from one country to the other, the resources. So multiple factors are involved. I think one of the major determining factors is the patient and also the disease. Depending on the first line of therapy, if you're able to give a monoclonal antibody plus an IMiD-based regimen, or even the most current DARA VRD type of approach or ISA VRD approach, then the duration of first response is so long that, and then the relapse refractory becomes a less and less important problem. But given the less intensive induction regimens, the problem of relapse refractory is bigger. And then here's the situation of how aggressive the relapse is. And are you able to afford waiting for the biochemical relapse to progress until a definitive treatment decision is made? And also, what is your prior line of therapy? And is your patient resistant to the prior line? And in that case, the scenario becomes, it's a categorized version. We recently published our national guidelines for treatment, including newly diagnosed and relapse. Earlier, the EHA-ESMO, which Dimopoulos was the leading author, the algorithm is vertical. But now the options are so much, we had to build up the algorithm vertical to allow so many combinations and drugs that are available in that line, which is based on VRD first line, LAN refractory, bortezomib or PI refractory, exposed non-refractory, and DARA-RD for front line, and then so on and so on. This is the first relapse. And then comes the subsequent relapses. And today, I think this will be my last sentence for this part, is not the number of drugs that the patient is refractory, but it's the class of agents that it defines. So double refractory, double class, or triple class refractory, instead of using lines of therapy as the prior for decision making.
Thank you, Meral, for this nice summary. So, Thanos, do you agree with Meral? And maybe I can push a little bit more because she mentioned the issue of LAN refractory. And actually, in the article we're going to discuss, there is a special focus on these subgroups: LAN refractory, early relapse one line, and the PI naive. What are your thoughts? What is your algorithm today?
Right. I think you are correct. We have an increasing population of patients with myeloma who progress on lenalidomide, either maintenance or continuous therapy. And also we have another group of patients who are progressing on an anti-CD38 monoclonal antibody. The use of proteasome inhibitors is now more restricted because usually the patients get a limited course of treatment, especially those who are younger, 4 to 6 courses before they move to high-dose therapy. And then subsequently, at the time of relapse, they relapse off proteasome inhibitor. So this is less of an issue than it used to be in the past. Furthermore, as you pointed out very nicely, we have a functional high-risk group of patients who are those who progress, I would say, even within 2 years of high-dose therapy, especially when they are on lenalidomide maintenance. This is a subset of patients that has a poor outcome. And we have done an analysis a few years ago, and we found that approximately 1/3 of these patients were classified initially as revised ISS1, meaning these were patients that they were supposed to do very well. So there are other factors that we have not yet identified that may confer this secondary resistance. So I believe for patients who progress on lenalidomide maintenance, it is important to be able to switch class of agents. We have done also an analysis a few years ago where we analyzed patients who were progressing on lenalidomide, and all of them received pomalidomide dexamethasone. And what we saw is that those that had another regimen with a different mechanism of action that was given after lenalidomide resistance, but before exposure to pomalidomide, they had a better outcome. So I believe that the usual combination that we used to have for patients who progress on lenalidomide, which is like Dara-Pom-Dex, may be becoming less and less relevant because now we will having many patients who will be also exposed to anti-CD38. So definitely we need drugs with a new mechanism of action, and especially if these drugs can be given and synergized with other agents, such as, let's say, a proteasome inhibitor, that we know that now few patients are, at least in the second line or even in the third line, truly PI resistant.
Excellent. Thank you very much, both of you, for summarizing very briefly and in a very nice way a very complex and rapidly evolving field. So now let's dig a little bit deeper into this article, and for just clarifying for the audio. Well, by the way, this is an interactive live activity, as you may have noticed. So please, guys, don't hesitate to share your questions, your comments, your suggestions, and I'll do my best to share this with the panelists. So in this paper, that was a post-hoc analysis of the Boston trial. So I'll not come back to what is selinexor. It's an XPO1 inhibitor, and we do have, since more than 10 years actually, very robust scientific rationale for using it in lymphoma, but also now in myeloma, where it is approved, because this XPO1 pathway, signaling pathway, is involved in the proliferation and in the survival of the malignant plasma cell. So it's definitely a very attractive target. So Meral, you didn't participate into this analysis and this study. What did you think about these results? Your general thought, and then I'll ask Thanos to walk us through these results.
Well, I think it's the subgroup analysis retrospectively is very important. And when you read the first report, you always wonder about some questions pop up. And the study authors are very clever, and they bring up those subgroup analysis later one by one. And one of those subgroup analysis of this study, the Boston study, is this paper. And another one which I found very interesting was the impact of cytogenetics, and that's another paper published earlier. And so regarding the previous topic, prior lines of therapy, here the Boston study included patients between 1 to 4 lines of therapy. And so this is a very heterogeneous group. It's worthwhile to look deeply into it, and based on the combination, I mean, half of the patients are after the first line, it's the first relapse. So this is a very good number. Out of the 400 patients, 200 in the experimental arm, and half of these are with a prior 1 line of therapy. So there is a good number of patients who have had lenalidomide prior to it, and who have not received at all a PI, bortezomib. From that perspective, the results, the survival curves, the PFS curves that you have shown is very important, gives a very important signal, showing even with len refractory, without having a need to change to another drug, another class of agents is giving a significant impact. So the p-values are important. So that's an important conclusion and the striking part of the study and the paper for me.
Thank you. Excellent. So, Thanos, you are a co-author. Can you walk us through about some of these results and why you feel they are important?
Yeah. First of all, let me, just summarize the clinical development of selinexor, because I participated in the first study, the STORM trial, which led to the approval of selinexor with dexamethasone several years ago in the treatment of myeloma. With that study and with selinexor given on high doses on 2 consecutive days, we saw responses in penta-refractory patients, about 25%. FDA thought that this is worthwhile to provide an approval, but with significant toxicity, primarily vomiting, nausea. We will discuss it later, I guess, asthenia, loss of appetite. In the Boston trial, this problem was mitigated because selinexor was given on a weekly basis at a lower dose and with proper antiemetic therapy that, again, is also evolving. Thus, in this study, the first analysis, which was published a few years ago, showed a definite benefit of SVD versus VD. In this particular sub-analysis that we are discussing, we have a longer follow-up, which is more than 2 years, and the primary focus is what is the impact of prior therapies on the outcome of the patients. So first of all, we saw that there is a benefit for lenalidomide refractory, which is even greater if the patients are lenalidomide refractory in the first line of therapy and then SVD is given as a second line of therapy. One striking difference is the PI naive patients, where we saw a median PFS which was 2.5 years. And this is probably one of the longest PFS. And if I could guess, and if we had a higher number of patients, we could see that within the bortezomib exposed or PI exposed patients, there were some patients who had received, let's say, who were bortezomib free for 4 months, but others for 3 years. So I believe that definitely for someone who has received only 4 months of bortezomib, then he underwent high-dose therapy and he relapsed 3 years later on lenalidomide, this patient most likely would behave as a PI naive. So one can extrapolate that for patients with prior exposure to bortezomib, which is today relatively limited, and on lenalidomide maintenance, one would expect that this combination, if given in an appropriate way, and we can discuss it later, and with an appropriate prophylaxis, you can provide to the patient an outpatient regimen with low levels of infections, which is important, that would give a meaningful progression-free survival. I know, Mohamad, that today all of us are very excited by the very effective CAR T cells, bispecific monoclonal antibodies. These are wonderful drugs, but I can tell you that CAR T cells are not readily available. They're not reimbursed in most parts of the world. And even if they are, there is a production problem and significant delays for the patients. Bispecifics are easier to get. They're very expensive, but also their effectiveness comes with a cost of significant infections. And as you know, the infections that are associated with bispecifics are not just for a restricted period of time. They go on for a long period of time, as long as the patient receives this drug. So yes, you have efficacy, you have MRD negativity, but also you expose the patient to treatments that are potentially toxic as far as infections, and also sometimes life-threatening.
No, thank you, Thanos, and I'm glad you brought into the podium some of these concerns, because first of all, regarding accessibility, we at the ICH are always advocating for the AAA project, I call it: affordability, availability, accessibility. And of course, this is really important. And the reasons and the arguments you have brought are exactly why we're doing this journal club. We're trying to be balanced. We discussed a lot CAR T cells, bispecific. We did a few webinars, and we want to take into account all available options, because the patient will need all of these options. So Meral, Thanos, when he gave his a summary about the development, and he has been involved, I think like yourself, you will tell us more about this, since many years with the development of selinexor. He highlighted when it was used as a single agent at high dose, the issue of some side effects, which, by the way, are not life-threatening. These are not like lethal, life-threatening opportunistic infections, but I think they alter the quality of life of the patient. I wouldn't love to have like a permanent nausea or weight loss myself if I'm treated for a given disease. I think there are now some measures that one can apply to optimize the tolerance of the treatment. What is your recipe, I would say, today?
Our experience with selinexor dates back to 2015, when Pharma was producing, and we started to have a compassionate use program, and the company was very generous. And since then, we have treated in our center like 20 patients. And during the course of the years, we experienced as much as the producer and the investigators and the people worldwide have experienced. We learned by treating patients how to approach the most severe nausea that I have ever experienced outside the context of mucositis in the stem cell transplant, which is a very transient one. But here in this sense, you have to prevent emesis for months continuously. And the initial doses that was recommended for us was 100 or even 120. We started with such high doses, and then we learned that it was not necessary to give those doses in order to be able to reach the maximum efficacy. And slowly we dropped to 60, very rarely to 40 milligrams. And initially, correct, it was twice a week. And then we converted to once a week. And the initial recommendation was 5-week cycles. We sometimes had to increase that to 6-week cycles to allow the patient to have some rest. But the antiemetics, I mean, I don't deal with oncology, I don't deal with solid tumors, but the oncologists, medical oncologists are very accustomed to dealing with nausea, and they are very confident with drugs such as aprepitant. And so the first time we started using EMAND was for this drug. You have to start 1 day early, at least, to be able to achieve the maximum antiemetic potency, and you can give it for 3 days. But so we were able to manage, and we learned how to deal. And strikingly, I have had one patient, for instance, has been able to continue treatment for 2 years, and he had very refractory background. So this was we used it in combination with bortezomib, and the synergism between selinexor and a PI is very, very important. when we started using bortezomib, NF-kappa B was such a very important thing. We were always talking about NF-kappa B, and now with selinexor, it's for sure, it's shown metabolically that it has the capacity to interfere, and that's how you kill the myeloma cells. And so not just by preventing the export of proteins from the cell, but also keeping the tumor suppressor proteins within the cell. There are, I think, three phases of this combination that makes it effective. And so based on our experience, we have learned how to control emesis and thrombocytopenia, which has the second highest important problem. And we have started to use L-Thrombobec in combination and to prevent frequent infusions. And it's also effective to give, and you can keep the platelets sufficiently enough to allow the next course of treatment or the next dose of treatment.
Thank you,
If I
Meral.
may add, Mohamad, I agree with what Meral said. So our approach is we have treated more than 300 patients with selinexor on trial or as a standard of care. So lately we use Akinzeo, which is a combination of netupitant with palonosetron. This drug has to be given before the administration of selinexor. And by using this drug and by starting at a lower dose, it is very important. For example, it's better to start at a 60 milligram, and if the patient tolerates, you can go up to 80. And if you have a small lady with a body surface area of 1.5, it's better to start with 40 milligram. Actually, as you know, there is a study published with selinexor indicating that patients who had a dose adjustment actually had a better progression-free survival, meaning that there is the right dose for a particular patient. Apart from Akinzeo, we use also NK1 receptor antagonists such as aprepitant, and also we have found that low dose of olanzapine can be efficient as an additive. So it is very important to use prophylactic antiemetics, and then after treatment to use antiemetics on a scheduled basis rather as needed. So this is something that we do. We are adjusting the timing of selinexor administration. So we are recommending to take selinexor with a small meal or snack, which sometimes can reduce dose. And also, sometimes the patients experience less nausea when they take the selinexor before they go to sleep. And usually, they may have some nausea while they're sleeping, so this is not very important. We encourage the patients to stay very well hydrated. We provide dietary counseling because, as we know, dehydration may worsen nausea. We ask them to take small, frequent meals like crackers or toast may help, and also to avoid strong odors or foods that trigger nausea. Another issue that we can see sometimes is hyponatremia, which is not only related to vomiting, but also can be as an only side effect. So for these patients, we encourage them to take pills that include salt. Other patients, we had a couple of patients who by themselves asked for help, such as acupuncture, and they reported that they had a beneficial effect. So I believe that over the years, we have learned how to mitigate some of the side effects. And in my mind, it is important, as Meral mentioned, for the patient who is having a benefit to be able to continue treatment and not to discontinue an effective regimen because of side effects.
No, thank you very much, both of you, for sharing these really very important and practical aspects. And I can hear from both of you that we have in hand a relatively very good drug. It's an oral, easy-to-use drug. We know how to manage the side effects, which are not very serious in terms of being life-threatening or high grade. And I think both of you alluded to the fact that we are maybe have been historically neglecting this issue that patients are only exposed to bortezomib for a short period of time. So actually combining a new agent, a new drug with bortezomib is almost feasible in everybody, because I'm not aware of patients who are resistant to bortezomib actually. Some patients cannot receive it because of peripheral neuropathy, and now it's a generic drug. So earlier we mentioned, you, Thanos, highlighted the fact that not everybody has access to immune therapies, and definitely using selinexor in combination with VD is a great option. We have a question here, a little bit more provocative. This is apparently a colleague who have access to CAR T cells, but actually because CAR T cells take some time, and we need to do bridging. And actually, if the patient is already refractory to all the other available agents, how would you do bridging? Can we use actually this kind of regimen like SVD as bridging for CAR T cells?
Yeah, I believe it depends on the type of progression. I mean, definitely, if you have a biochemical progression, or you have a progression with typical myeloma features, and the patient is not refractory to bortezomib, one may want to consider that. However, if you have a rampant progression with extramedullary disease, as you know, we would rather go to some form of combination chemotherapy with novel agents, depending on what the patient has been exposed to before, DT-PACE, ESAP, and regimens like this. This is something that can be seen on a patient-to-patient basis. As Meral pointed out, there is evidence that selinexor-based combinations have activity in patients with adverse cytogenetics, even 17p deletion. We know that this activity is not permanent, but it can give you, some leeway for the CAR T cells. And also, there are some interesting reports, a small series of patients, on the efficacy of selinexor-based combinations in extramedullary disease. And also, it appears that there is a CNS penetration.
And actually, I can confirm, because in the single agent trial, which was reported actually in the New England Journal of Medicine, we included a few patients, and one of them has an extramedullary disease which responded for almost a year, which is actually
very interesting.
Great. Meral, any thought on this bridging issue?
Yeah, I think I would like to add one thing, that there is in vitro data that supports that selinexor induces T cell fitness, which can be used during the pre-CAR T and also post-CAR T period, which the Würzburg group is very keen on. And the other thing is regarding the extramedullary disease, that's one of my topics that I'm very fond of. During one of the EHA meetings a couple of years ago, 19 patients from the STOMP analysis study were presented, just the extramedullary disease, and they had fantastic results with the selinexor combination. There were patients, these are relapse refractory cases, don't forget, they are not frontline extramedullary. So I think the issue that we have higher expression of secondary events, cytogenetic events such as 17p deletion, RAS mutations, and those which are higher among patients who present with extramedullary and also in the extramedullary tissue. So for those reasons, a combination of selinexor can be helpful. And the last sentence, which Thanos mentioned about penetration to central nervous system, that be taken into account. Well, I was discussing with some colleagues from the Gulf region 2 days ago, a case in the central nervous system involvement, and we discussed the option of selinexor with them. And so these are the scenarios where we don't really know which partner is the best partner for selinexor. Maybe Thanos, he has more experience regarding other drugs, but POM for sure is a good drug for 17p deletion, and so in this setting, it is a good partner.
Yeah, outside the clinical trial, we have managed to give selinexor with calfizomib, also in some patients, and I think this combination at least is without unexpected toxicities. And also, as Meral mentioned, with pomalidomide, there are some data with daratumumab, as you know, in the ongoing, small phase 2 studies. Because of the unique properties of the drug, it can be combined essentially with all other agents with myeloma. So the moment that you can get hold of it, of course, the indication is with SVD in 1 to 3 prior lines of therapy, but then you can, if you can find the way, you can combine it with other drugs to cover the need of the patient.
Wonderful. So my last question to both of you, well, for you, Meral, where is selinexor positioned today in your practice? And the last question is going to be to Thanos. What are the next steps? Because you've been involved in this development for many years now.
So I think based on this manuscript that you have shared, the early the use of selinexor, the better. And since it's an oral regimen for patients who do not want to visit your clinic very frequently, and if you can combine with an oral agent such as POM in a earlier relapse with high risk, I think a choice between a monoclonal antibody-based regimen versus this one, this may have a priority in a high-risk patient in my mind. And for late relapses, and in that category, or for a patient who is CD38 refractory and who has been exposed to lenalidomide and refractory, then here you have another still a position for this combination. I think what we learned through the years was how to manage the GI toxicity, which is the critical part of which requires the experience of the center. And our colleagues' experience is very helpful in this sense. I had not heard about Akinso before. Only last week when Evangelos Terpos was visiting our country and for a meeting, he mentioned about it. That's how I hope we will be able to get access to it in future.
Thank you, Meral. So, Thanos, what's next? You have the privilege of concluding.
Thank you very much. So I don't think I have much to add besides what Meral said. Selinexor is a drug that, is more or less available with different ways. So I think, different schedules and combinations in early setting in order to delay the use again of an IMiD, such as an IMiD-based regimen as pomalidomide, and to increase the IMiD-free interval, which we know will have a better effect. There are data that for patients who have been previously exposed or progressing on anti-CD38, there is activity. So there are some real-world data that are collecting such patients to see whether this could be and additional drugs for the new double refractory patients, meaning lenalidomide and anti-CD38, and also potentially what Meral mentioned, and we need, of course, more data regarding the ability of selinexor to interact with T cells. There is a lot of discussion about T cell exhaustion, T cell engagement, and whether you can modulate this, and maybe, in the future, combinations of selinexor with bispecifics. Who knows? There are many ways and many unmet needs. I mean, by increasing the life expectancy of our myeloma patients, we are creating, quote unquote, a higher number of unmet needs subpopulation. So it's not like 15 years ago we had lenalidomide refractory, bortezomib refractory, and that's it. Now we have anti-CD38 refractory. We will have anti-BCMA exhausted patients, and in the future, bispecific refractory. So there is a lot of area for clinical and translational research.
Thank you, Thanos. Thank you, Meral. This was really a fantastic discussion. To conclude, today's Journal Club has provided, I think, a comprehensive look into the treatment landscape for multiple myeloma, and from its unique mechanism of action as an XPO1 inhibitor to its clinical efficacy and safety profile, I think selinexor has proven to be a valuable option for patients with relapse refractory myeloma. I really appreciate the depth of the discussion with our two panelists on how this treatment can be effectively integrated into clinical practice to optimize patient outcome. Thank you all for joining this Journal Club and engaging in this important conversation. As the treatment landscape for multiple myeloma continues to evolve, it's crucial to stay updated on emerging therapies like selinexor that offer new hope for patients. So we encourage you to take the insights shared here today back to your practice. Let's continue working together to advance care of in multiple myeloma. This is the ICH around the globe and across the hematology field. Take care and see you soon.
Thank you very much. Thank you. Bye-bye.
Bye-bye.